of all, I want to wish you a very warm welcome. And we are very happy that everybody here is joining us for the occasion of World Cancer Day in this beautiful setting, which is the Olympic Museum of Lausanne. And now I would like to say a few words on cancer prevention, because there is the very classical notion of cancer prevention, which is divided into primary cancer prevention, secondary, and tertiary cancer prevention. Primary cancer prevention is mainly located on the population level. And this entails, in fact, preventing the development of cancer. So, for instance, by making some health choices, your diet plays a role. Cessation of tobacco is very important in this primary cancer prevention. Also, reducing UV exposure to reduce the risk of cancer. But what may be less known is that diversity also plays a very important role within this cancer prevention. We are all different, so your age can affect your cancer risk. Our ancestries can affect our cancer risks because we have different genetic backgrounds, and some genetic backgrounds may be more prone or susceptible to developing cancer than others. Of course, we also have a very important difference between males and females, and how do hormones affect cancer risk between males and females? Why do some populations respond better to treatments than others? This just shows how important diversity is as well in the field of cancer prevention. Now, if we move then to secondary and tertiary prevention, secondary prevention is important at the level of individuals. So here, the main characteristic of secondary cancer prevention is to make sure that cancers are detected at a very early stage, or the treatment of pre-malignant lesions. And pre-malignant lesions are changes in normal tissue that may potentially be cancerous, but it's very effective if it's already treated at that stage. And finally, tertiary prevention is also at a very individual level, where the really targeted therapies play a very important role. Or after resection of a tumor, what is your risk of having a secondary tumor afterwards, or your risk of recurrence?
Now, why the skin? The skin is really an exciting organ. It's a multifunctional barrier. It's important for organ cessation. We sense touch, temperature, and pain. It's also very important for psychosocial function. It reflects our health status. You can immediately see if somebody looks healthy or not. It forms an essential barrier. It protects from water loss, invasion of allergens, irritants, and pathogens, and also from UV radiation, which you will hear later in the second presentation today. And unfortunately, this protective barrier becomes less efficient with increasing age. Now, skin cancer is the topic of today. Skin cancers come in different flavors. The most common one is the so-called white skin cancer, the major forms being basal cell carcinoma and squamous cell carcinoma. And a certain percentage of these squamous cancer result from precursor lesion, with actinic keratosis in sun-exposed skin being particularly common. Now, in addition, we have the black skin cancer, which is even more dangerous and aggressive, and in spite of very good treatments, a lot of patients still unfortunately die from melanoma. Though the incidence is huge, it's by far the most common white skin cancer, is by far the most common type of cancer in humans. Basal and squamous cell carcinoma affect 3 million people globally per year, 15,000 alone in Switzerland. And the black skin cancer melanoma is less common, but still it has 2,500 new cases per year in Switzerland, and it is actually a very high number compared to many other countries. Now, our approach is the following. We start from patient material, and in rare exceptions also from mouse material, but generally from patient material. Then we collect this patient material and analyze this using modern molecular technologies, so-called omics approaches. Then we get a huge amount of data, and we use our bioinformatician to integrate these data in a computational analysis, which results in the creation of hypotheses and identification of candidate targets. These targets are then validated in 3D organotypic skin cultures and eventually also in mouse models. Then it comes to formulation and patient application in the drug testing, and eventually we go back to the patient.
But now we have a more public view, not really the experts in the industry or in dermatology. So I focus on 3 questions. Do the sunscreens work? because there's a lot of anti-sunscreen lobbies and talk and conspiracy theories and everything now. I'm not going to go into it. I'm certainly not going to show it to you. That's bad communication if I would do it. But it's out there. And then which sunscreen should I use and what should be actually the message? So this, I think, is appropriate for this forum here. So since it's general, I use this ChatGPT, the generative pre-trained transformer. So just to check also for myself what we in the last 20 years actually trained for this transformer, because it only takes it from what has already been out there, right? So I have 2 questions. Recommendations to protect oneself from the sun. And then you will see a second question which is similar, but it's not giving exactly the same result. So the first is exactly what is generally, you hear a lot. First, use sunscreen. Second, seek shade. Third, wear protective clothing. This is exactly the wrong order, as I just said in the beginning. So, but when you ask, and you see that here actually confirmed by a dermatologist, Isabel Casas from Argentina. She, I call her Dr. House for the name. So she says that this is the wrong thing, to focus on the sunscreen, but it's done sometimes. And when you ask a second question, how to prevent skin cancer, actually GPT gives you the right order. First, what is it? First, limit the exposure, right? Avoid the sun. Second, protective clothing. Only third, sunscreens. And you can see here a good example from one of this other book, which you can also have a look, which I recommend highly. This example shows the difference between being in Tenerife the whole day, or in Edinburgh the whole day, but in Tenerife, the second time, you go out of the sun for 3 hours. And then you get less total exposure to the sun than in Edinburgh. So that's quite an impressive example, I think. Shows nicely what we are talking about. And this is really a really highly recommendable from Brian Diffie. He's like one of the Pope of sun protection, the primary prevention. And so I just encourage you to have a look at this book.
And so the question that we have been interested in the lab has been to understand why it is that breast cancer is on the increase, and that got us interested in hormones. And I will try and explain that a little bit over the next couple of minutes. And so since 2020, breast cancer has become the most frequent cancer worldwide. And that although it basically happens only in half of the world population. Now, the good news is that we have made enormous progress in treating the disease over the past decades. So now, if you're diagnosed with it, you have 85% of chances of dealing well with it. But we still have the number of cases globally increasing, and there's also the worrisome trend that we see more breast cancers in younger women. A phenomenon that is not limited to breast cancer, and which is why also this issue is close to my heart. So I think we need to do something about this. Now, what plays into breast cancer risk? And so there are some factors, such as age, that increase your risk to get the disease. There is also the family history that plays into it, and high breast density, which is having very whitish tissue on a mammogram.
I asked questions. I possibly asked too many questions. I know that at times I was considered a bit of an awkward patient, Why was I asking so many questions? Well, I was asking questions because I didn't really understand how I could have ended up with a 5.5 was the measurement, 5.5 centimetre tumour 6 months after a clear mammogram. And that is what led me on to starting Being Dense. So we talk about breast density, and Being Dense just came up, was a family conversation shortly after Christmas. And yeah, I'm very, very, very proud of it. So just to give you a quick run through, this is a photograph of my last screening mammogram. So this is the one that came back clear. So I got a letter following this screening to say that my mammogram was clear. And that was in June of 2015. And in November, nipple change, and December, diagnosis. So, when I got a copy of this, I was fascinated to see that there was a note. And the note was from the radiographer. And the note referred to the extreme pain that I had felt during the compression of my right breast, not my left breast. And I wasn't a newbie. I had had several mammograms. So I knew that there was, well, I didn't know. I felt that there was something different, and we discussed it. I might come back to that because radiographers actually are advised not to converse with the client. And I know that because we've discussed that in UCD. So University College Dublin with radiographers. They're there to take an image. They're not there to give any advice or to, you know, and I think that's a shame. I think we need to see more involvement and more discussion. And, you know, our imaging is so important to anybody because that sets the tone for your treatment.
So this sums up a little bit about what Catherine was saying. It's an old paper, but when you look across the whole of the countries that you see there, if you can see it, breast cancer is increasing in all of them. And the question is, why? And Catherine went through some of the reasons, and a lot of them are to do with hormones. And the work that's going on here to dissect what hormones is just groundbreaking. It's just right up the top there. So, more hormone exposure. Periods start early with sort of general, if you like, quotes, civilization. The use of oral contraceptives, later or no first pregnancy, late menopause, use of HRT and obesity and so on. But these, I think, are the major non-hormonal factors for breast cancer. You have a family history, but family histories don't change very much, but these do with time. So I think the founder of prevention is this man, Bernardino Ramazzini, who said an ounce of prevention is worth a pound of cure. I guess it is, if prevention doesn't cause problems. And he described the high frequency of cancer in nuns, and he was interested in occupational diseases, and he called being a nun had an occupational disease of getting breast cancer. So just to feed back, if we're going to do prevention, I guess you want to target hormones to start with, and that's what we've done. And so the development of hormone blocking treatments come from the clinic, but they usually come from advanced disease clinic because that's where, as you know, drugs are first used in women who unfortunately had cancer that has come back, and they volunteer for studies. And it's just wonderful the number of volunteers we've had over the years to the trials that we've done to help women. And then if you have a couple of drugs which seem to work in advanced disease, and the two I'm talking about are tamoxifen, which is an old drug developed in breast cancer in Manchester in the 1970s, and anastrozole was also first used in Manchester in about 2000 or 1990s. They worked here, So what you do is you give them after surgery for breast cancer to see if they prevent relapse, and that's widely done. Now you give 5 to 10 years of both of these drugs, tamoxifen for premenopausal women largely, and anastrozole for postmenopausal women, and it helps prevent recurrence of breast cancer. So if they work here, why don't they work here? And in fact, many years ago it was shown in a so-called adjuvant trial, the people treated with tamoxifen got half the amount of cancer in the other breast, and women who were on the placebo. So that's where it all comes from. So there are no cures here still. Many women are cured after surgery for breast cancer, thankfully, because of these drugs and others. And many women have their disease prevented by these drugs. Now, a bit of mechanism, and why put these funny diagrams on here? This is the picture of the structure of the estrogen receptor, which is central to all of this.
And finally, my colleague Manu will talk more about electronic cigarette, but I just want to mention that we have these new products coming into market. And in 2022, the Swiss market of disposable electronic cigarette increased of 2,200%. And this is not my data, it's data from the companies, the disposable electronic cigarette companies. And so this is a fake advertisement, my first vape. But we know that we have a real crisis in disposable vapes among teenagers and youth. We should wait what? Until kids 5 years old, they start to vape? I mean, we should wake up. If not, we will get a crisis. Actually, we have a crisis on that. In Switzerland, prevalences are not getting down, and consumption of all new tobacco and nicotine products are getting up. And finally, Africa, and lower middle income countries. In the 20th century, we had 100 million deaths related to tobacco. And if the trends continue like that, with the increase of consumption of tobacco products, especially in lower middle income countries, we will have in the 21st century 1 billion tobacco deaths related to tobacco consumption.
So in the EU, 700,000 people each year die of tobacco. And times 50 people who get sick of tobacco. So for me, the tobacco industry is like the Hydra of Lerna, a very poisonous snake, the Greek mythology, which Hercules had to kill. He had to chop off all the 12 heads. I will come to that later, which 12 heads that were. For every head he chopped off, 2 heads returned. And what you probably don't know is that the industry is really seeking for growth. They need new customers. And all new customers are children, are youngsters. And from their private documents, we know that they see our children as their only source of replacement smokers.
Diacetyl, it causes lung disease. It produces fine particles which can, the chest physician, Wanda can tell us better, which can actually penetrate even the smallest of the alveoli and cause lung diseases. So yes, it's not actually that it's harmless or it's a boon which is given to us. These are known carcinogens. These are known harmful causing chemicals which are present in e-cigarettes. Let us also talk about nicotine, which is the whole premise on which e-cigarette market is based. Do you know what is the most addictive substance in the world? We were having a very interesting discussion during dinner last night. And I did a casual search, ChatGPT, which is the most addictive substance in the world? Number one is sugar, and number two is nicotine.
But certainly, and this is in collaboration, we are very much interacting with an oncologist, Bernard Ozdemir here at the CHUV, and Dorothea Wagner. And so there are important differences, not only in the susceptibility on the survival, but also in the toxicity and the response to various chemotherapeutic agents, or even in the anti-cancer immunity between males and females. And so this is another example of this fluidity, this complexity, and this interplay between sex hormones and chromosomes. And so it turns out that, and so obviously this is a binary decision whether or not you have a Y chromosome. But actually there is an interplay between the hormones and the chromosome whereby you can actually have individuals that have a female phenotype but are actually genetically males, because you actually can block the signaling of these hormones that actually will affect and determine sexual differentiation altogether. And so the final link is not only ancestry, not only sex differences, but also aging. As I mentioned, I'm old, and I'm keep aging, I guess, like good wine. But when a man just gets old, one thing that happens is actually the levels of testosterone in the blood decreases quite significantly. And at the same time that testosterone decreases, the risk of cancer is increasing. This is actually not only in the male population, but also the females, and there is evidence that androgens, as also Katrin mentioned very much, is also very active and very important in the females and not only in the males. And so this is the final slide here, where we are experimentally also focusing the laboratory on these androgens, male hormones. And so the evidence not only prostate, but we are working on melanoma, but now with Anne, we are actually writing an exciting review on the role of androgens in all cancer types. And so the overall, there are some exceptions, but overall, androgens are promoting cancer development in many cancer types. But it's also well known, and that's part of the thing, that actually also the decrease of androgen is an important determinant of aging. And so whether or not you can modulate positively or negatively androgens in this context will determine the well-being of people of different races, of different ancestries. But also there is abuse. And so bodybuilders or people that take anabolizing modulators for androgen signaling can also impact on this whole big picture of fluidity.
We were not just looking at screening awareness intervention. When I was working, I saw that there was no way to measure the impact of our intervention, and we really needed data management. And in Africa, I won't recommend we go into genetics and all those things as you are doing here. We needed a very baseline data for reference, a population-based cancer registry, just to track, to understand the burden, okay, and also to monitor the impact of our intervention. Because we were working and there was nothing to, measure our impact. So I started engaging existing health institutions, those who are treating cancer, because when we detected these early cases, we referred them to these facilities. So I also promoted establishment of cancer registries in these facilities.
There is nothing left for me to say, but to thank you all for being here today.
I'd like to thank Anne for this fantastic job. It was all done thanks to her. So thank you much. And to next year.